Unit 5, Part 2, investigating the various medical scheme benefit option structures available. Let's carry on. Above threshold benefits. To mitigate the risk of running out of savings account funds, specific schemes offer above threshold benefits to members who have medical savings accounts. These insured benefits can be accessed once a member has exhausted their medical savings accounts funds and have qualifying claims paid from the savings account that amount to a threshold. The claims that count towards this threshold are usually claims for more essential healthcare services. A member cannot, therefore, spend all their benefits on cosmetic surgery and then claim the above threshold benefits. No, we cannot do that. Some schemes exclude specific claims from counting towards the threshold. For example, over-the-counter medication, and some limit the amount of a claim that will count towards the threshold. For example, amounts paid to practitioners that exceed the scheme rate on the RPL or a multiple of it, and amounts for spectacles that exceed a limit. So most schemes have a threshold that exceeds the annual contribution to the savings account, so that before qualifying for above threshold benefits, they enter a self-payment gap and must pay a certain amount of their claims from their own pockets. So for you, those of you that are new, that don't understand the threshold, I'm going to try and explain it to you. So let's say for a certain things they said, okay, the scheme will pay up to 2,000 Rand. That's the limit they will pay. And then they will pay the amount above the threshold cap. They will only then pay from 5,000 Rand upwards again. So what is in the middle between 5,000 and 2,000? We talk about the gap. This is your threshold gap. There's a 3,000 Rand difference in this gap between that line and that line. All right, so when you've got the claim here, the scheme will pay until they get to 2,000 Rand. When you put in another claim here, they will say, no ways, Jose, we don't pay. Here you've got the gap. You need to pay that gap yourself. Only when it reaches 5,000 Rand, then you pay again. So they try to distinguish people who want to misuse this benefit, whatever this benefit is. They try to stop people to misuse it. But if the people don't really misuse it and they must use it for that limit, and they are willing to pay the difference, the 3,000 Rand, out of their own pocket, and so out of their own pocket. So this 2,000 Rand plus the 3,000 Rand then gets to 5,000 Rand. Then the medical agent, okay, you're now above the threshold, and from now on we'll pay the rest. And that is what they're basically telling us here. I hope that makes sense to you. So the self-payment gap will be larger than it appears if claims paid from the savings account either do not count or do not count in full towards the threshold. So sometimes the amount will be very small, or there will be no amount at all. It depends. So they said, no, from 0 to 5,000 Rand, you must pay, but you'll only pay from 5,000 Rand upwards, if I can use the previous example, which I just explained to you and showed you on the previous slide. So once the member qualifies for the threshold benefits, in other words, when you reach that 5,000 Rand, rules may apply of these benefits. For example, there may be exclusions. Okay, we'll pay this, but not that. Limits and services that may only be paid for at for at a rate. Okay, we'll pay not this but that, but only at 100% rate or 200% rate, not at 500% or 400% as the specialists require. But the thing is, they will carry on paying. When a scheme sets up a capitated option, so when you look at capitation options, it enters into an arrangement with one or more healthcare providers in terms of which it agrees to pay the provider a pre-negotiated fixed fee per member in return for the provider supplying a certain medical service to members. They'll say, okay, we'll pay you this fee, but then we want you to give this service to the members. And then they negotiate that with the healthcare providers. The said fee remains the same regardless of how many times the provider has to provide the service to the member of the type of services the member needs. Although the services that will be supplied may be limited by the contract agreed between the scheme and the service provider. The service provider will say, okay, I will do the same, but only for this specific member 10 times or 15 or 20 times. That's the limit for the fee the scheme is willing to pay. Capitated options transfer some of the scheme's risk to the provider as the provider takes the risk that the fee will cover the services it must provide. The scheme has certainty about its costs. Most capitated options have capitation arrangements for day-to-day healthcare benefits and control the costs of hospital benefits in other ways, such as by way of preferred provider networks or monetary limits on benefits. The two large providers that offer services on capitation basis are PrimeCure and CareCross Health. PrimeCure has medical centers in certain areas as well as contracted practitioners. CareCross Health is a network of private practitioners. So CareCross Health also operates a private practitioner network aimed at the middle income market called One Care. Medical scheme options using these two providers typically offer unlimited access to doctors within the respective networks, also unlimited medicine on a formulary and basic dentistry, optometry, radiology, and pathology benefits. Some schemes offer cover for visits to a specialist, but often only if the member are referred to by the network doctor. So you cannot decide on your own, I want to see a specialist. You must first see the network doctor, and the doctor will then decide whether you need to go to see a specialist or not. So discounted network options and preferred provider networks. Many schemes are now using provider networks to limit the cost of benefits. Several schemes are offering what the CMS refers to as efficiency discounted options, where the contributions can be discounted typically between 10 and 20% if the member agrees to give up some freedom of choice when it comes to providers. Members who do not want to limit themselves to using certain providers only pay the full contribution rate, while members who do pay the discounted rate, all other benefits are equal. The Medical Schemes Act states that all members on an option must pay the same contribution rate on that option. The lower contribution rates on the efficiency discounted options are allowed in terms of an exemption from the Act. Most schemes offering discounted contributions for restricted provider choice have a hospital network limiting members to certain hospitals only for elective procedures. However, some are also using pharmacy networks to achieve savings and reduce contributions. Schemes are also setting up networks of providers who agree to charge the scheme's rate for certain services. And members are not obliged to use these providers, but doing so ensure that they not have to pay part of the bill out of pocket. Now, this is exactly what I choose. I told my broker I want the best as possible for as little as possible. So he also told me that I must choose this option, the core plan on my medical scheme. I also work with a network of hospitals in Pretoria. There's a 5, which I can choose from. Luckily, the ones I wanted was part of that 5. So, but then I told him now I'm on a holiday in another province, the coast maybe, and I've got a problem and I need to be operated. Then he said, but if it's an emergency, I can go to any hospital where I am. But if it's not an emergency, if it's a planned operation, and I want an operation, but I want it next month, then I cannot do it at the coast. Then I must arrange and plan, and um, and then I must choose those 5, which is fine by me. Then I'm closer down. The same with the pharmacy network. If I choose to get my medicine from any clicks or discount, then I can go on to that cheaper plan, which I'm fine with. But some other people said no, they want to take it to get their medicine from their pharmacist, which is not part of the network. Then they're gonna pay some more. So yeah, that is how this works for me. I don't have a specific pharmacy to get my medicine. Any clicks, which is what is nice is if I'm on holiday in a town and I need to get my medicine, I can go to any clicks or this scheme and I get my medicine. No problem. The providers are in turn incentivized to charge the scheme's rates through direct payment arrangements in return for being paid directly by the scheme and not waiting for payment from the member. The provider accepts a lower fee. These networks are typically general practitioners, GPs, or specialist networks. One sizable open scheme is offering members who use its GP networks unlimited GP consultations. So you can go as many times as you want for GP consultations. And that's paid from the risk benefits. While another is offering GP consultations with the network GPs paid from your risk benefits when saving account benefits are exhausted. So it depends from one scheme to the another. One has got it this way and the other one's got it that way. Selecting the correct benefit option depends on the health status and requirements of the individual and his or her dependents and what they can afford. Health status and requirements change, and thus members must review their requirements on at least an annual basis. In other words, every year you must check your health status for everybody, the member and the dependents, on an annual basis to ensure that the option that are on continues to meet their needs. Also, medical schemes annually review and adapt their benefits and contributions. In some instances, interim changes to the contributions and benefits occur. So you must also look, okay, you're happy on this plan, but then you must look, oh no, my medical changed the benefits as from next year. Now you've got a problem. Now you must either go up or what are you going to do about this situation? Members are allowed to change their options annually without being subject to underwriting. That is true. Some schemes allow members to downgrade during the benefit year, as we said before, whereas other schemes allow members to upgrade if faced with a life changing event, being diagnosed with cancer, then you can upgrade. The reason the majority of schemes do not allow members to upgrade is to prevent anti selective behavior. Anti-selective behavior is basically when a member pays for a lower option and then when he or she requires access to a more comprehensive option, they can apply for an upgrade. So the members want to pay as little as possible and have the lower benefits, but then they get the situation, the problem, and then they need the operation or something, and then they quickly want to upgrade to get that benefit. So anti-selection is also seen when the young and healthy decide to stay out of the medical scheme system until they need to access healthcare benefits. Anti-selective behavior results in ineffective cross-subsidization at both a medical scheme level and a benefit option level. So the steps which should be followed when deciding on the most appropriate option is detailed in this Unit 5 in both the member and intermediary sections. Here we are going to look at selecting the appropriate benefit option. So a member needs to ask the following questions when deciding on the benefit options best suited to meet his or her needs and that of his or her dependents. So the level of cover required, if you look at the hospital benefit, if you just want the hospital plan, is it unlimited or is an annual limit acceptable? I know some hospital plans, I don't know if it's still, but when I looked at mine, some limited you at 750,000 for hospitalization, others was at 1 million rand, and others was unlimited. Now, I had a friend that was in a very serious motorbike accident. He was at a very famous medical scheme and he had 1 million rand hospital cover. And he thought that was good enough. In that motorcycle accident, the car struck him on his motorbike. He lost his right leg and his right arm. The right leg was amputated. He still got his arm, but he cannot use it. It's just hanging. And the reason they left it, they said maybe in future, medicine will develop that they can give the use of his arm back to him. That's why they didn't want to amputate the arm. The arm didn't get that bad hurt, so he's got his arm just in a sling. But they had to amputate his right leg because the car struck him on his leg. So he was in hospital for months. And what happened? That 1 million rand ran out. No more. So he had to go from a private hospital to a government hospital. Luckily for my friend, his employer, he was working for a big group, well-known group in South Africa. The company said, you will not move him to a government hospital. He will stay in the private hospital and we, the company, will pay the medical bill, which they did. Nice to them. Hats off to them. Well done. So, yeah, luckily for him, the company paid that hospital bill. When my friend told me this, I decided I'm not looking at anything with a limit. I want unlimited. Because my employer might be so nice as to say they will settle it. He might not. He might not be able to afford it, although they want. I don't know. But I am not taking any chances. I want unlimited. So I took unlimited hospital cover. That is important to me. Unlimited. So I took that one. Reimbursement rate at medical scheme rates or above. I was not too worried about that. So whatever is whatever. Will co-payments and other deductibles be applicable, be acceptable? Yes, I accept that. Network or freedom of choice, I was happy with network. So yeah, that was my choices and I was happy regarding my hospital benefit. So that one sorted. So then we looked at chronic cover. There's no cover required. No, I wanted cover. Only PMB conditions, that is fine. Comprehensive chronic benefit required. No, I wasn't bothered about that. Free choice designated service provider. No, network is fine with me, for me. And treatment protocols and drug formularies, nah, it's all right. I'm not. So I was happy with that. Tick, done. Day-to-day benefits. Okay, let's look at my day-to-day benefits. Choice of providers. Um, ach, um, yes, I took providers. Luckily for me, my doctor is part of the providers. So that's free choice. Designated service provider. No, that didn't bother me. Treatment protocols and drug formularies. You said no, I get my medicine. Same the PMBs. Benefit limits and co-payments. That wasn't an issue. Disease management program, cancer, diabetes. Yes, if I get that, I don't have cancer or diabetes, but if I do get it, yeah, I would like to have it. So that was my tick boxes. So benefit exclusions, more restrictive on low-income network-based benefit options. So I was a network-based. Not that I'm low income, but network-based option suits me. So yeah, if you want to say I'm low income, that's also okay. But I'm trying to save money. Affordability, yes, I could afford it. Loyalty and wellness programs, yes, that is there. So now you can presume I'm either one of the two. Age and life stages are essential factors concerning benefit options selected, as these factors are directly proportional to claims experience and subsequently gives guidance to the options selected by members. I don't think this was really a problem. So the graph below illustrates the concept we just did now before. Okay, so this was the benefit exclusions we looked at. You see, and this is how you must look at put your medical scheme, your hospital plan savings out, and tick what you want and what not. So age and life stages are important factors with regards to benefit option selection, as these factors are directly proportional to claims experience and subsequently give guidance to the option selected by members. Then the graph below illustrates this concept. We're going to look at the graph just after this. So let's look at stage one here in the left in the yellow. You're a young single member. You want hospital cover, unlimited or no day-to-day cover. Yes, that is what they name. When I was young, I didn't really bother about day-to-day cover. Stage two, now you become a bit older, you become a bit more mentally stable, um, and you get married with children. So you need hospital cover, you need day-to-day cover, maternity benefits, yes, because there was one baby, but probably number 2, 3, 4, 5, 6, 7, 8, 9, 10 will also come. So you definitely need maternity benefits if you want 10 children. Limited chronic benefits, yeah, you're not that old. Chronic is not that serious problem, so limited is fine. Then when you get seriously clever, the old people, the Mandalas, they are the clever people. Retired, you definitely need hospital cover, higher day-to-day cover, and higher chronic benefits. That is true. That is so true. So let's look at that graph. On the left-hand side, you will see here we've got average claim per beneficiary, PB, per beneficiary per month. So it's 200 Rand, 400 Rand, 600 Rand, 800 Rand a month, 1,000 Rand a month, or 1,200 Rand a month. Here at the bottom, we've got the beneficiary age. We say under young, that is the newborn babies, up to the age of 1 year. You see, their claims, it hits there, so it's about 600 Rand a month. Then we've got the 1 and 4 year olds and the 5 to 9s. You see, they are quite low. They are not expensive. I'd suggest about 100 Rand a month. It's their expenses. Then it goes a little bit up, 15 to 19-year-olds. And if I can, sorry for my artwork, yeah, they hit about the spot at 200 Rand a month. Then we 20 to 24. Then it goes a little bit higher up. Oh, sorry for my artwork, about, I think, 300 Rand a month, I would suggest. Then the 25 to 29-year-olds, if you have to, sorry, I'm trying, yeah, they're going to hit about 400 Rand a month. 30 to 34, it's about the same, 400 a month. 35 to 39, I don't know what's happening there, but it's a bit less. I suggest here and here as well is when children are born. And maybe some illness as well. And here might be some illness, but people don't get children not really. The overall people, you might get people between 35 to 44. And now my one friend got had one daughter when she was 40 or 41, so she will fall in this bracket. But it's minor, so that's why this is low. And you see here from age 45 to 49, yeah, it's about level, I would say. So people are quite healthy there. 50 to 54, it rises a bit up. If I can draw with my free hand, oh, sorry about that one. But it should be around 500 Rand a month, I would suggest. Seems to me. And then here, 55 to 59, it goes up again. I think this one will hit the spot around about 600. Let's have a look. Yep, yo, 600. You see, and then from 60, it goes up. It goes up. Now here from age 60, we look at 800 Rand a month, 65 to 69, going up again. I think this one will hit the spot about 900. Yep, it's in half of them. And if you look at 75, you see it goes up again. This one will hit the spot around 1,000 a month. Yeah, 75 to 79 years old, it's going up again. I think this one will hit the spot at about 1,100. Yo, sorry, I tried to draw with my free hand as best as I can. So yeah, it will cost the medical 1,100 Rand a month. The same with the 80 to 84, they will roughly be the same. A little bit less, maybe 150. And then from 85 plus, it is coming down again. And I suppose the graph will go overall down because at that stage people start falling away. Yes, you do get your people at age 90, 95 and so on, but they are so few that it doesn't have a big, huge impact on the medical scheme. And that's the end of Unit 5. I hope you've learned a lot. And any questions, you know what to do. And have a lovely day. See you in the next unit.